And I'll be recording this for the other class and for you guys too. But so a lot of you are looking at some of the elements and saying, is it social? Yes. Okay, what diagnoses have social focuses? And those type of things, instead of really conceptualizing the whole picture of what's kind of going on, and kind of hearing the whole story. So we want to focus on that a little bit and try to get you some information on how to conceptualize a case, not just diagnose. So diagnosing is something you do in the midst of a conceptualization, but a conceptualization is what's actually going on in the story. In this case of Gwen, we know that there is a major transition kind of going on in a couple of different areas. She's transitioning from the bulimia and the inpatient, and she's transitioning from the stages of life and the children growing and things like that too. So then the question comes in, so which is better? Is it more of the transition in general that she has going on, or is it the actual stage of life? So they both fit. You could go the stage of life type of thing, but I kind of gave you the adjustment order in most cases. And I didn't grade off on it as much as there's just a few things that are just kind of graded off on, but for the most part, the biggest issue wasn't the conceptualization, although that's something we want to focus on. We also want to focus on the treatment planning, because the treatment plans were all over the place. And what I mean by that is some of the treatment plans said therapy, outpatient therapy. Well, that is what you're writing a treatment plan for. So it's not just that she needs outpatient therapy as a treatment plan. It's that as an outpatient therapist, what would you be doing to treat? So as an LPC track, that's what you're on. LPCs would be treating the diagnosis. So what would you kind of implement into the treatment plan? Some of you nailed it, did really well. Some of you really just kind of were all over, which is fine. Again, not a huge issue. It's just we want to narrow the scope down to what are you going to actually do with the client to help address that. Now, that being said, you're probably thinking, I don't know, that's why I'm getting a master's degree. So I would expect that. This is a really good book. I'll show it to the video here too, just in case you're looking. But this is really good. This is a great book. I'll pass it around. It's the Therapist's Guide to Clinical Interventions, 1, 2, 3 Treatment Planning. You don't want to there's a couple of different kinds of this. You don't necessarily want to copy out of this type of thing. You can just pass it around a little bit. But it's a good guide of you see something, you're like, I don't really know what I would do with that from that direction. That's what it's for. Eventually you're going to get to the place where you kind of have your thing, that's how you treat anxiety, how you treat depression, which theory you operate from. And then you'll do stuff like this. You'll go to trainings. This is a CBT training on OCD for children. I'm going to give you some stuff off of it. But, once you realize you want to do CBT, you find the training that deals with OCD and CBT. So you pick up the different skills you kind of want to pick up as you're kind of working through stuff. And so, incidentally, the other book that I brought for you to look at is the OCD workbook. Some of you may have seen this, Barnes & Noble, whatnot. It's a pretty good book. It's got some really nice techniques in here, things that are printable. You'll see some of it's marked up because I'm OCD. No, I'm just kidding. I actually bought this used. So you'll see some of it, but it has there's a lot of these type of books that are decent that you can kind of go through too. So I'll pass this around too so you can kind of see some treatment planning guides and books. So I would encourage you to start getting some resources on these things. When you start seeing various disorders you're going to maybe want to deal with, or things you might see in the scope of what you actually are going to do for work, so we want to kind of do that. So anyways, that being said, let's kind of get into a little bit. We're going to be switching from a couple different resources, and some of these resources are from different avenues and disciplines, and I'm doing that on purpose. So I want to kind of cross-train you guys a little bit interprofessionally. So like the PowerPoint we're going to look at now is actually for psychiatrists, medical doctors. So I cut out a lot of it that's actually medical doctor stuff, and I want to kind of focus on the OCD part of it too. So we're going to go from the OCD, and then we're going to get into the DSM, and we're going to look at a different presentation, PowerPoint on on DID and on disassociation. And so we're going to cover a lot of territory in this. I will try to give you some other resources on PTSD. There's in the crisis class, I do a lot of different videos and a lot of different things on trauma response. I don't want to show you a lot of movies in here because
the title is on here.
Yeah,
Therapist.
1, 2, 3's therapy guide. Yeah. So yeah, we're going to kind of go through that a little bit and give you a little bit of perspective on that as well, so you have a general understanding of that diagnosis. Now, next week, we're going to review for your exam midterm, so you have a general idea of what's going to be on that. The following week after that, you're going to be doing the midterm in here and not in class, so we won't have class. So anyways, let's get started. Let's get into OCD a little bit. So I would ask if anybody here has OCD, but since you're all grad students, we probably have tendencies. So just in general, we want to kind of find out a little bit about OCD and compulsive disorder of OCD. It's an anxiety disorder, generally in the DSM. It's recurrent, unwanted, distressing thoughts or obsessions or repetitive behaviors or compulsions. So compulsions are behaviors, obsessions are thoughts. You're going to need to know that. Okay, I don't know if it's on the midterm or the final, but you're going to want to know that in general. Not just, mixing those up a little bit, because you're going to find people who have obsessions, and you're going to find people who have compulsions, and then you're going to find people who have both. And you really kind of need to know what that is, so you have a general idea, so you can kind of get a good concept of what's kind of going on there. So anyways, so the majority have both though. Most people you see will have obsessions, and the compulsions are how they're acting out on their obsessions. A lot of them you'll notice the compulsions, and people around will go, yeah, they're so OCD, and they use it as an adjective, okay? So like, she's OCD, and so a lot of times when people say that about a client, don't take it as face value of like, ooh, OCD. I mean, you're going to want to explore that, because sometimes they're not OCD, and it's just an adjective that's kind of a demeaning way of addressing their mom's behavior or whatever. Sometimes they are OCD. Sometimes you'll miss OCD. OCD is easy to miss because people don't often present with it, and sometimes it's at a lower level, so it's actually super helpful. Like, they clean a lot. The house is always spotless. Their house is spotless when I go over there. That's not a negative thing. Like, that's something like people are like, yay, we don't want to fix that because that's awesome. The house is all spotless, But then you'll find some different types of behaviors that can be pretty difficult. I'm aware of one case that a young couple got married and didn't realize that one of the partners was OCD. They didn't live together, Christian couple, good couple, just didn't realize that there was OCD behaviors. Really thought the guy was super clean, nice clean cut, always looked great, didn't realize. But it sounds different when you're in a setting where you're talking with them, and they say something along the lines of, yeah, I thought it was kind of weird that he made me take my shoes off every time I got in his car. You're like, okay, that's weird, right? You're like sitting there going, that's super weird. Like, but that person the car was spotless all the time. To the point where they lived in an apartment complex and they didn't actually eat in their house. They ate at the grills at the apartment because they didn't want to re-clean everything. I mean, bathrooms being cleaned, top to bottom, scrubbed 4 times a day till 11 o'clock at night, waking up middle of the night, getting out of bed, and re-scrubbing the bathrooms. Significant problems in the relationship from what you originally saw at the tip of the iceberg was they're really neat and they take care of themselves. And below that was vacuuming at midnight. So the pattern on the floor would look right because somebody may have stepped on it since 9 o'clock p.m. when they vacuumed the last time. So, you're going to see those types of, that's a pretty extreme one, but it's, again, that behavior is meeting a need. So all behavior communicates, and all behavior has a purpose. Okay, so understanding that the compulsive behaviors are serving a purpose to alleviate tension, possibly caused by the obsessions or other issues. So majority have both though. Sometimes they know it's senseless. Sometimes they know they do it. Compulsions usually reduce anxiety but are not pleasurable. They're not happy they did it. It alleviates tension. So they feel the tension. Yeah.
So do the compulsions have to come with the obsessions?
Nope.
They could be separate. Okay.
Yeah, so they may obsess over certain things, and the compulsions may be completely different. The compulsions might alleviate the obsessions, but that's not always the case. Sometimes it's childhood things. Sometimes it's people coming out of different things. They've been traumatized. On a lower level of traumatized, talking about traumatization, a lower level, you'll find a lot of people coming out of the military having compulsions like that, or having obsessions, or one of the two. They may have compulsory behavior where things have to be in order. You'll find that people coming, they're getting off their ship, they're getting off the base, they come home, and then laundry's sitting in a basket, and they're like, why is there laundry in a basket? Because they came out of an environment for the last 12 hours that has been nothing but this is, that level of ramped up. So they come home and they get anxious, and they're like, why? This should be done. Things shouldn't be left undone. They're not used to coming to an environment where things are undone and not completed, because people get punished for that where they come from. So you can find, where there's some marital conflict over stuff like that, because it's just they're not in that environment, but yet they still have that behavior. So that's a compulsion where it's no obsession. The compulsion is actually from them trying to alleviate the tension of what they could get in trouble for, just because it's there, even though there's really no chance of that happening. So they have kind of both, but they're kind of acting in a way where it's alleviating that tension more than anything. And so you're going to find people who lack control or have lacked control in childhood will try to meet things in a certain way. You're going to find patients that have they've had problems with their parents, maybe, where dad used to dad was never late. Their kids would be severely punished if they got in the car late. They were never late anywhere. And then they get in a relationship later, and they're like, we got to go to church, and you're like, I don't know, what should I wear? Maybe I'll change this. I thought I had shoes to go with this, but I don't. And they're like freaking out. And they're like, get in the car. We have to get in the car. They're like, why is it? Why? Because when they grew up as a child, they were punished for being late. So their mind is still in this pattern of this type of thing. That's the kind of scenario where you're going to have somebody say, well, they're so OCD when it's time to do whatever. And when we do this, they're always, where they're alleviating tension, but that may not be OCD. And so, that's the kind of thing where you're going to find, you see what's related between those two is the alleviation of tension. Is that somebody grew up alleviating tension from their parents by acting a certain way and being early, and now they want to alleviate potential tension even though their parents are not present. They still are trying to fight that tension, because they're living on their own, they're away from home, but they still have that tension that's ramped up. So you'll see that. Symptoms produce subjective distress. They can be time consuming. They can interfere with function. You can imagine if you don't eat any meals in your home, in your kitchen, because you don't want to get things dirty, and then your partner's got to re-clean them, and then they're going to take the blender and break it apart and clean it and dry it, put it back together, take it apart, clean it and dry it, take it apart, scrub it again, clean it, make sure there's nothing on it, dry it, and if there's any spots, they'll dry it again. You're talking about 45 minutes of cleaning up a blender after you use it. You're going to find you just leave the kitchen and go, it's not even going to the kitchen, because the whole night will be nothing but the kitchen. So the problem is, you can imagine how tormented an individual is when they're constantly trying to alleviate that tension. So obsessions are recurrent, disturbing thoughts, impulses, or images. They could have a feeling of, I'm going to be in trouble, I've got to take care of this, that type of thing. It could be intrusive. Not just excessive worry about real life events such as generalized anxiety. So generalized anxiety disorder is excessive worry about something real. This is an obsession about something that may not be data driven whatsoever. So you got to watch the difference between those things. You got to see the difference. So if you have a client that was involved in a violent confrontation on the school bus, and when they're worried about getting on the school bus, that's not an obsession, because they're anxious about what happened and what could potentially happen. Where if somebody's washing their hands 7, 8, 9 times, there could be that obsession. Someone's all night gets up in the middle of the night, go downstairs to check the locks and relock the doors. That could be an obsession. If they heard a noise and they went down to investigate and double check the door locks, that's not obsession. They're responding to something. So that's where you kind of get into some differences there a little bit too. And you're going to have to kind of weed through those different things. So obsessions, attempts are made to ignore, suppress, or neutralize the thoughts with some other thought or action, usually a compulsion. So they're attempting to neutralize the feeling of the thought and the obsession by doing something. And it could be kind of busy work. It could be cleaning. If I'm cleaning again, then it's something what you're going to notice a theme on with OCD is generally people have a compulsion related to something they had very little control over at one point in their life. And they're acting in a place they do have control. So they are their finances are in a rad place. They're going to clean their car and they're going to clean it again. Everything's going to be perfect in their car. Because they can't fix that problem right now, but they're going to fix this. So people will kind of be caught up in things that they can't have control over. To alleviate the tension, they look back at that and go, see, that's perfect. Things at work are difficult. They go to a job that's thankless. They get blamed for everything, so they go home and cut their grass, and the grass is perfect. And you're like, man, those people's lawns are meticulous. I mean, that lawn looks amazing every time I drive by it. Those people generally have areas of their life they can't control. So they're going to control that lawn, and it's going to be perfect. There's tension at home. They go in the workshop and they want to start building stuff. They're going to paint a new bookshelf or whatever. They want control over whatever they're doing. It's not because they really want to paint the bookshelf. It's that they really want to alleviate the tension by demonstrating something they're doing in that moment that they have control over. And so you'll find people to get plugged into those things intentionally to do those things to alleviate tension. So again, like we said earlier, if I'm standing in the corner of the room back here and you're going to say, wow, he really likes the corner of the room. Well, maybe I really hate the door. So my obsession or my compulsion to stay in the corner doesn't have anything to do with liking the corner. It has to do with not wanting to be near that door. And the degree to which I stay in the corner is directly related to how much I hate that door, right? So that's where you're kind of looking for with the OCD. There's always something driving that behavior. It may be related, it may not be, but in adults, if you start looking back at childhood, you're going to find it. And when you look at onset, you're going to see in a minute here, a lot of this begins in adolescence. So we'll get into that too. Do you have a question?
Yeah, I had a quick question. With most disorders and things that we diagnose, do you find it's usually because, metaphorically speaking, it's because they hate the door or they're afraid of the door rather than because they love the corner?
So that's a good question. It's all over the place with that, because sometimes there's people who, they're not anxious about something because something happened. They're anxious people. They got up. Like I had a client tell me once, my son's been like, because this will throw off your entire paradigm of treatment. When you're trying to treat somebody and all of a sudden they're like, he was like that ever since he was like 1 year old. My son, when he was like 16 months old, I'll never forget, I tried to paint the cabinets in the kitchen. And he had a temper tantrum, went over to the kitchen, the cabinet doors, and tried to pull them off and tried to block it with his body. He wouldn't let me change them. So he resisted change at 1 or 2 years old. And so it's not that something happened where now he has this obsessions. It's that he's trying to alleviate tension. What else do people do that sometimes is a compulsion to alleviate tension?
Smoking.
Okay, substances, good. What else? Eating, yep. Still, that's substance, but go ahead, good.
Exercise.
Exercise.
Hand washing. Hand washing.
Mm-hmm. That's OCD-ish, yeah. What else do people do? You'll notice that's the reason for self-harm. So cutting, those type of things alleviate tension as well. There's a level of control over that pain, and you're releasing endorphins from the healing of things. So you'll find people who cut and have that type of behavior where they're doing self-mutilation, self-harm, sometimes have a tendency toward OCD in some other areas. So they're cutting, they're mutilating, and they're acting out in ways that they have a measure of control, because sometimes pain they're experiencing they didn't have control over. They don't have control over things at home, their parents fighting, or pain about their friends rejecting them and thinking things, all the kids at school making fun of them. So they'll cut and they'll do different things in order to try to have some measure of control. Which means it's not what? It's not a suicide attempt. That's not a measure of control. It is sometimes, but I mean, it's fatal, you know. So you can see kind of the difference there. When you see somebody who's doing some kind of cutting their wrists, are they trying to give a warning sign of suicide, or are they just cutting and self-harm type of thing? So you want to look at that kind of behavior as well. So, so the person knows their own thoughts, but you got to figure out what kind of the deal is with that as well. Typical obsessions, contamination. You'll find aggression, safety harm, sex, religion, somatic fears, or need for symmetry and exactness. Does anybody know anybody like that by chance? Where everything has to be lined up in a certain order? Yeah. Yeah. That's an obsession. That's an area of order, you know. Unfortunately my dad has died, but I did that to him a lot. So like we would go in his office and we would move pencils around in different order, you know, and then he would come home from work and he would sit down at his desk. You'd hear him kind of sitting there, sit down, put his briefcase down, walk around. He'd stop for a second. Who's been in here? Like you know right away, like somebody messed with his, you know, somebody just took a pencil and moved it to the other side. Or a pencil had to be constantly sharp. He never had a pencil that was remotely dull. He would sharpen each of them, place them exactly how he wanted them. So when he picked them up, they were all ready. And so, but again, my dad grew up in downtown Milwaukee in a very low income area. There was a lot of very severe racial issues. He lived in a very poor home. His mom, he started working at 12 years old to feed the family. And so when you look at his childhood, you're like, wow, he didn't have a control over a lot of things in his life, fought hard to make sure they even could eat. So for my dad, the slippery slope of losing the ability to feed his family was a pencil not being sharpened. So you see how the compulsion and the obsession is all those little things. He would get into the chaos of, he's very loving, great guy, but he would get into this like, my world's out of control. I'm going to sit here and do this. My dad wanted the same. My dad had on his calendar, he had a calendar written out, and he had exactly in this multi-year calendar on what day of what month he would flip the mattress in what direction. It was all scheduled out for years. You could flip into 3 years later and say, oh, on that date, we're going to go flip it from the bottom up and rotate this way. For Christmas, he wanted the same thing every year. And he was really happy if he got it. He wanted 12 Pepsodent medium toothbrushes, which is a brand of toothbrush. And he wanted 24 gold toe black socks to replace all of his black socks. His pillow was labeled. Should my mom and him ever mess up the pillows when making the bed, that his pillows were actually labeled with his letters on initials on it, so they would always be in the right place. So that's obsessive behavior, right? Okay, so, but that was a matter of control. When you look back at the childhood where he's out of control, and all those little things lead up to he needs control of his world, you know, because that's his security, is his ability to control his world. And so for the things he couldn't control, he would focus on the things he could control. And so, so those are the type of things you can see in that kind of behavior you'll notice for different things as well. Repetitive behaviors, mental acts, the person feels driven to perform either one. So it could be a mental act, it could be a different kind of behavior as well. Again, designed to reduce stress, distress, or prevent some dreadful event from occurring. In my father's case, the dreadful event that would occur would be poverty, right? So to stop poverty from coming, he made sure everything was in order and he was meticulous in everything he did. And so, truth be known, if the pencils were dull, he would probably still be employed, right? So, but again, it was that slippery slope where he wanted to control what he could control. So he had rigid rules on different things. So designed to prevent or reduce the stress from preventing something from happening, and then the everything is pretty much excessive or senseless. Yeah. No, go ahead.
Would you say that kind of life would lead to workaholism?
Could be. Because again, that kind of behavior is like you have control over your future because you work hard. Those type of things. Yeah.
The rigid rules that you're talking about, are they normally applied to the person, or do they apply to others too?
They usually apply to their own environment because again, the focus is their control. So the problem will come in. Let's say a child doesn't have, like a child they can't control. So can you imagine that a young couple I told you about having a baby? Where baby decides to throw up, what do you do then in that house? Or a baby has a toy. If that toy, even owning a toy, would be instant red flags and sirens inside the OCD parent's head of where's that toy going to go, where's it going to be, it's going to mess up the carpet, there'll be no more lines in the carpet. So that was a big concern because it's so excessive that other areas of life that are pretty normalized don't mesh as well because of the obsession. So it's not that they're trying to project it onto other people, is that they're trying to control their environment, and people who are necessities that infringe on that, they have the same rules. So, my room could be messy. My dad didn't care. He cared a little bit. Normal. Just normal amount of caring. Other things, just kind of, if I washed his car, that would have to be meticulous, and I would never do it right. So to this day, I'm really good at washing cars because it's not that I'm obsessive. It's that I was taught how to keep wash a car properly by somebody who is obsessive. And so I don't actually wash my car, I run through a machine. So I don't care that much. So but I know how to do it. And I know how, but again, I have no pleasure in it because it turns into this obsessive thing that's not really let's make the car look good, so it is. Typical behaviors though, cleaning, washing, checking things, order, arranging, counting, repeating things, hoarding and collecting is also the same thing. Let's talk about tics. Tics are involuntary, sudden, recurrent, non-rhythmic, stereotype motor movements or vocalizations. Does anybody know anybody with tics? Or see anybody? Yeah. So they have random movements that can occur. They can be suppressed to some degree, but you'll see they are a compulsive action that happens biologically. It's not that in their mind they're saying I should do these things, and because it makes me look super weird. They're not trying to do those things. Sometimes they don't even know they do them. They may have agoraphobia too. Yeah.
I'm thinking of an individual in particular, but with these tics, would you think that while they're doing the compulsion, they would still have the recurring tic, or would the tic be maybe suppressed while while the compulsion is going on? Does that make sense?
Yeah, it does. So the difference lies in the two terms biological and behavioral. So they may have a biological response, which is the tic,
right.
The body reacting, where the behavioral response is them actually doing an action. So they may be independent of each other, they may be at the same time. I've never seen anybody with a tic engaging in their compulsive behavior at the same time.
Right.
Matter of fact, I can't even think of anybody that's had a tic and a behavior. I know people have had tics that have not had behaviors that were obsessive, but
Do you mind demonstrating a tic?
Well, it'd be any kind of movement. It could be anything. It could be a head twitching.
Would
Yeah.
rocking be a tick?
Would what be?
Rocking.
Could be. Rocking's more autism.
But it says non-rhythmic, so the rocking's usually.
Yeah, but again, you're talking about a tick is going to be just any kind of movement, like their head just jerked to the side, those type of things. Yeah.
I work with a set of twins in school, and each week they'll have a different tick, like constant blinking or stretching out their hands, but they can't control it or jerking their head back and forth. So
Yeah.
they do it without even realizing it.
Yeah. Yeah, they don't typically realize they're having that kind of a behavior or response. Compulsions are seemingly purposeless, but always in response. Sometimes, well, they're not always in response to obsession, like we said. Tics from compulsions: complex motor tics, facial gestures, grooming behaviors. They may rub their head, touch their face, jumping, touching, stomping, smelling an object. Those can be motor tics. Tic-like compulsions: touching, tapping, rubbing, repeating routines, evening up behaviors. Whatever they're kind of doing. They may have specific behaviors though that are really more compulsions than muscle movements. It's a big difference here. OCD, chronic tic disorder, types of them. You can see some of the things here: aggressive, contamination. So you have with tics is yellow, without tics is blue. So you can see really aggressive tics and behaviors typically come with aggressive compulsions come with tics typically. Checking things often come with tics. Repeating things come with tics more. Touching come with tics more. Symmetry, somatic, those type of things can come with them. Symmetry is always interesting, where people have to have everything in order and those type of things. Yeah.
What was the second kind of tick? You said complex motor tics. What was the second kind?
Yeah. Where it's comparing the compulsions. So symptom continuum, we're going to talk about continuums a little bit today. Obsessions, compulsions. You have obsessions or fears, anxieties, harmful avoidance. They're avoiding punishment from a parent that was severely intense, a very authoritative. Authoritative parents produce a lot of this. And so they are avoiding that harsh, harmful interaction. And even though that parent's not there, they feel like if they do this behavior, they will avoid negative interactions. So we all develop an understanding of patterns of interactions based on our early childhood experiences. And so that's why there's so many things that can really be affected there in early childhood, which we're going to get into later when we talk about trauma. Intrusive ideas too, are obsessions, just things that keep coming up, like I'm going to be robbed, someone's going to break in and steal everything. That's an intrusive idea. So you go down, check and lock the doors, and you're laying in bed, you're like, probably get robbed. They're going to break in. They break in the back door, then you go down again. You get up 3-4 times a night to make sure you're safe. That's where you kind of get into a little more of the intrusive ideas. Tension reduction, just right with risk taking, versus sensory triggers, unwanted impulses, and tics. Those are more compulsions. And so you have this blend here of the continuum where people will engage in certain types of behaviors. They'll engage here to kind of have this type of behavior interaction kind of going on. And so we do know childhood does shape a lot of this. We also know people can be treated for it. It's very successful treatment for this. So, yeah.
For risk taking, that would be like going skydiving or
Yeah, it could be
doing something.
any kind of compulsion where there's, some kind of a behavioral thing you kind of notice that's a little bit different, is a compulsion. You want to see a good one? Okay, so there's a movie out for rent called Free Solo. Anybody heard of it? There's a movie called Free Solo. Definitely check it out. It's on, you can like rent it on Apple now and that kind of thing. It just came out for rental. It's about one of the guys. I know an Olympic coach, and he said this kid is probably the best athlete living in the world. And basically, he does what's called free soloing, where he climbs, and he will free solo he did El Capitan, which is this 2 mile high, 90-degree angle. He does it with no rope. He climbed. And so what they did, what's cool about it though, is not only that he does it and how he does it and why he does it, but first of all, you're gonna notice he's spectrum. He's kind of Aspergery. And then like when he has interactions with his girlfriend's like, is there anybody who would stop you from taking these risks? And he said, no. Not even a girlfriend? No. Like he right to her face, like, no, you're not gonna stop me from doing this. So he does these things. But what they did is they did an MRI of his brain, which is so cool. And they found out his amygdala doesn't work like everyone else's amygdala. So he doesn't have that thing in our head that has that level of fear. And so the way he does things and why he interacts in this, you can tell it's a compulsion. He cannot not do it. So that's a great example of a risk-taking compulsion that alleviates a tension or an obsession he has. He doesn't get into what the obsession is, but he has this compulsion for his behavior. But it is what makes him such a great athlete is it's like if you're an Olympic athlete and you either win the gold or you die. That's your sport. Like you either win or you're dead. Like there is no silver. Like you're done. You fall for 45 seconds and explode. Like that's it. So, but watching him do this and the whole process of it is just a wicked cool movie to watch, and so you'll appreciate it. But it does show the brain with hands a little bit, the differences in the brain and what's kind of going on in the background in these areas. So you're going to see this kind of push-pull back and forth and the interaction between these two in a lot of scenarios. So patients reluctant to disclose unwanted thoughts and behaviors sometimes. They don't want to disclose them. They often don't want to talk about them. They may not even know why they do them. Typically they won't. If they come in to see you, and please keep this in mind whenever anybody comes in to see you, they're going to minimize. They don't come in and go see you and like, my life is in shambles. They're like, it's not that bad. My kids told me I should probably come in. I just really like things clean and they're messy. And you're like, oh, okay, well, kids can be messy. You're not even thinking like OCD. So they're going to minimize all of that. But people are typically profoundly hurting to come in to see you, to walk in the door of someplace. It's kind of like church. To have somebody off the street come into your church and sit there that doesn't know anybody, there's a strong driving factor for people to do that. That's not natural really. It sort of is, but it's natural in the respect that they're seeking to know their creator. That's natural. But I mean, church itself is not. You sit in a row, listen to someone talk like here, sing songs about blood. There's times you stand up and sit down and no one knows when it is except for everybody else. And you don't know. So it's a totally weird thing if you think about it. And so for people to come in and be like, hey, I really think I need to, it's good to reach out and see what's going on in their life and what's kind of going on. So sometimes people wait till they're really at the bottom to come and say, I really need to get some help. And so assume that people are worse off than they are when they come in to see you. When they call you and they're like, hey, I can come anytime, that means get them in now as quickly as you can. Don't try to wait until like, oh, good, because I have an opening in 2 months. You can ask them if that's not okay, see somebody else, but I have a waiting list. You can do that. But I mean, generally people are coming in because they're desperate. And so you'll see that here. They may not want to talk about their obsessive behaviors. They may want to talk about other things. But again, because they don't have it linked. The compulsions they're alleviating are not always linked in their mind to the obsessions. They just know they wash their hands a lot because there's germs. They don't realize I am obsessed with germs. They don't often say that. So they may not have the full understanding. Think of OCD patients presenting with depression or anxiety. This is a good screening question. Sometimes people are bothered by unwanted repetitive thoughts and sudden strong urges, check, wash, count things. Anything like that ever happened to you? So you're going to screen specifically for those type of things. What you may find though is that it's secondary. So if there's areas of their life that they're out of control in, and they feel like they don't have control, and they've had a childhood with a very strict parent, you're thinking, what is, you're like, okay, what's going on? You may be thinking, I wonder if they have any compulsions and obsessions. So you're going to start to find links the more patients you see where you'll start picking up on, oh, there are some, there aren't some, you know. What do they have control over? What are they trying to get control over? 2 to 3% childhood onset, 50%. So 2 to 3% of the population have it. 50% of it starts in childhood. So you're going to see a lot of kids with it. It can be chronic, women and men. The Brown Obsessive Study, age of onset, look at where you're starting to see here. You're looking at males, yellow, females, pink, 250 sample. You're looking at here 13 to 15, you can see it start spiking. And then 20 to 24, you see it more in females. We can hypothesize why that is. We really don't know. You know. Common chronic can be disabling. Can be episodic. Patients that camouflage their symptoms out of embarrassment. A lot of times they're embarrassed that they have OCD. They feel like it acknowledges that they're out of control in an area, when the whole point of OCD is to gain control over something they can control. So for them to admit and say, I do not have control over an area of my life, and that's why I do this, is asking them to do, you know, it's like somebody coming in for the first time with, you know, drinks too much, and you're like, you need to tell me you're an alcoholic right now. Like, you know, they're like, well, I drink a little, but, you know, it might take them a minute to get to that. So, you know, typically they may have other anxiety disorders and other issues going on as well. 50% before 18, higher occurrence with comorbid with tics, higher rate of first degree relatives with tic disorder, OCD. So childhood onset may be more familial. Why do you think that is?
Copying behaviors.
Yeah, they may copy, and they're living in that environment. To survive in that environment, they have to act a certain way. So they may have the behaviors, they may have compulsions before they have obsessions, if they ever have obsessions, right? Because they're just doing what, you know, they're going to get yelled at if they don't put that away. There's one thing on the counter that's not, you know. I worked with a couple once that one member of the dyad there, of the marriage, one of them was ADHD and severe, like, you know, ADHD, like just squirrel, you know, that kind of thing. Like, you know, it's legit, super, like just didn't follow through on anything ever. And she was extremely OCD. And they got married later in life, and they came together, and there was a lot kind of in there, and he was just kind of like, oh, things are good, yeah. Oh, I've got retirement, I've got stuff, and we'll be taken care of. And she was like, good, I can be taken care of, and let's do life. They had a lot of things in common, and they were like, let's do this. Well, she is super OCD, like she wants control over everything, and she went through a really difficult stuff in her marriage, some other stuff. So she is hyper like OCD, and so to the point where, like, how could you walk over the bird poop on the front steps and not clean it up the first time, you know? And he's like, I didn't know birds went to the bathroom outside. Like, I didn't know. Like, he doesn't even know like anything. But most of us would not clean our steps for, like, you know, if you ever saw a bird, you know, went to the bathroom on it. But very common for him to wash one dish in the sink and then leave another one on the counter, like thing, you know, that whole thing, which is like, you don't care about me. You don't even try, you know, just super like, you know, and he's like, I'll get better. I promise I'll get better. And he's not going to meet in the middle to the point where OCD meets ADHD. That's like a bad movie script, like, you know, because it just coming together is just not going to, they're not going to come that close.
Or
So
a good movie script, depending.
it depends. Yeah, it depends who's playing the characters. Yeah, but you're trying to get her to understand he's not going to get better to the level you think he needs to get better, and him to say you need to try to get as close as you can to what you can do. But they're not going to. They're going to have that level of tension there, and then so those things can really start to kind of have a little spin to them where they take on a little life of their own, you know. So. And so insight not required for making diagnosis in children. So just really you can see the behaviors and do it. So I'm not going to get into all this because we spent a lot of time on this already. But I'm going to go through this a little bit with you too, just give you just some general CBT stuff for kids as well. So you're going to see inconsistencies, waxing and waning, morphing symptoms, illogical type of stuff. So they may change a little bit. Because when they're not having the compulsion or the obsession, they're not going to have the compulsion. So the behavior may not be super consistent, especially with children. There's sometimes bizarre obsessions that you'll see. Some of them start to go into psychosis. You know, like the aliens are putting air in my air conditioning system, like chemicals are poisoning me. You know, that type of thing is more of a break in reality. Fear of leaving DNA. I don't leave my DNA anywhere, so if I touch the table, I'm going to clean it up before I leave. You know, that kind of obsession is a little bit different. Some people are obsessed with turning into another person. They believe they're going to turn into somebody different. Taking on another person's personality, contaminating an area, absorbing calories by touching food. So there's some people who feel like if they touch food, they're gonna take on that kind of thing too. Hunt, you know, being, you know, hurting any kind of inanimate object too. People can be kind of obsessed with, I don't want to hurt this, you know, that kind of thing. Yeah.
So some of the things that you mentioned, like with touching food and stuff, could that actually be also comorbid with anorexia?
It could be.
Something like that, or you even said like psychosis, because in here it says obsessive compulsive disorder with absent insight or delusional beliefs.
Yeah. So again, you're looking at, if you may have somebody with psychotic disorder as a break in reality, and then you may have somebody with super obsessive behaviors or obsessive thoughts. That is, they're after me, they're always after me, they're after me. Well, that's more obsessive than just hallucination. It's not like they're talking to a friend and having a conversation that's not there. That's more psychotic. So it's kind of like, you know, a burger with a side of fries with a side of a burger, you know, kind of, which is dominant. And so if you see the obsession more, you're going to go more with an obsession with a psychosis than if you're doing something different than that. So that's a good thing to bring up, though. Let's see here. Gets into that a little bit. I don't want to get into that.
Question. But
Yeah.
when you're diagnosing people, I know that, you know, if you see, how much is, I mean, can you I guess you can. You can over-diagnose somebody. You say, oh, I see this, and this, and evidence of these things.
You can, and some of you did. But you really want to look at the dominant thing you're seeing. You only need maybe one diagnosis. Sometimes there's more than one things to highlight. But what's the number one thing you're kind of trying to address? You know, so someone comes in to see you, they may have multiple issues, you know, but they may be coming in because they're really feeling depressed, you know, so you may start off with that and kind of see what's kind of leading into that a little bit too. So you may see some of those OCDs you see for depression, you know, or something like that too. But I do actually want to get into PANDAS real quick here. PANDAS is pediatric autoimmune neuropsychosis disorder. Subtypes, familial hoarding, tics we talked about. Some of it there's some hypotheses about serotonin and how serotonin plays into OCD. Glutamine, there's a lot of different things again on brain activity, what's being activated by what's going on in the brain. I don't want to get into that too much. Frontal lobes we know are invaded, and the basal ganglia are involved as well. So pediatric autoimmune neuropsychotic disorder associated with streptococcus is PANDAS. So PANDAS is an OCD that comes in children generally after they have strep. So some of you may not know, strep can cause a lot of different diseases. So we had a son. I have 3 sons. My youngest son developed strep and was treated for it. Strep throat. Took like amoxicillin or whatever they gave him, the Z-Pak. Got better, felt good. A couple days later, woke up just feeling kind of funky, feeling weird. And we noticed from his hands up to his elbows and his feet to his knees were blood red. They were just red. And so we took him to the pediatrician. The pediatrician said it's probably vasculitis, which means your blood vessels get larger. Vasculitis. And we're like, what made the blood vessels get larger? I mean, you know, pretty common question. We get he's red. That's what you're saying. And so then they're like, but he had a lot of pain and moving and stuff, and so they ended up looking, and then they're like, well, he probably has Rocky Mountain spotted fever. So does he have a tick bite? So they checked him for a tick bite, looked around, and finally they were like, we can give him a pill for a Rocky Mountain spotted fever. So we're like, oh, cool, he probably had a tick bite. So we take the pill, it gets better for like a day, gets worse again. So then we're like, okay, we'll stop playing around with this with our pediatrician. And so we go to CHKD Infectious Disease. And they do a bunch of tests, and they're like, it's not a tick bite. First of all, there's a blood test for that. They could easily run to see if he had something from that. And they start looking and stuff like that. And anyways, what he ended up developing after strep was rheumatoid arthritis, juvenile rheumatoid arthritis. And so he has intense pain in his joints from moving his joints. He's gotten a lot better. He's no longer red, but he had a lot of joint pain. And they said that is one of the side effects that can occur after strep throat. So, but again, this is a specific strep infection that comes across, and then you start to have some kind of behavior or symptoms after that are related. And so just kind of letting you know that. Behavioral therapy can be good, exposure. So, so you can have somebody sit and say, okay, I want you to go home, and I want you to cook some popcorn in the microwave. Take it, eat it, and then I want you to just sit and observe what's in the kitchen. Feel how you feel in your body, and just focus on your breathing, focus on whatever. In other words, you're going to have them expose themselves to a mess, a controlled mess, with the purpose of trying to help them do whatever. So with a client, I would say, okay, so go ahead and at 9 o'clock clean the bathroom, and then go upstairs, and you're not allowed to go back in that bathroom until morning. You can clean in the morning if you want again, but you can't go back in the bathroom. You do not clean the bathroom. And so getting them to sit, you're going to want to. You're going to have this tension that says, I've got to go down there and do that. And I want you to deal with the tension this way and give them different skills. So you can teach different responses, and eventually, if you look at the workbook, you can eventually get them to the place where they become, a little sensitized to the triggers of it, and realize they can kind of deal with that a little better. Serotonin reuptake inhibitors, SSRIs, help as well. Behavioral therapy doesn't care where it came from. You change the behavior techniques. So it's exposure and response ritual prevention, ERP, is one way of treating it. So that can be beneficial too. Severe depression or some other things. OCD and depression related, how they're related. I don't get into that too much. SSRIs, different medications, which ones work. I don't want to get into that either. Increasing number of positive reports for clinical predictors of schizo obsessions, delusional OCD, or tic spectrum OCD. So there's a lot. They're looking at some of the connections between some of these things as well. I would encourage you to read as much as you can on these issues, because there's a lot of good stuff to understand with it. For example, there was a article that came out recently this week on people eating healthy foods, and if you eat healthy foods, that you're likely to be less depressed. And so they took people who scored a certain range on a depressive inventory, and then what they did was they broke them into two different groups. One of the groups, they had eating healthy food. The other ones continued eating what they were eating before, and found that the ones who ate healthy food had a pretty significant decrease in depressive symptoms. Here's the problem, is that while that did help with eating, right? The other side of that is that the people who were eating healthier foods made a proactive change in their life and took control over an aspect of their life they probably weren't happy with. So was it taking control and having an intentional behavior that you can control in your life that is a positive one in your own mind? Is that beneficial, or is it the actual food? So they didn't really control for that variable. So it'd be very interesting to see what they say for that. But ECT can help. Vagus nerve stimulation. We were talking about that. neurosurgery. The surgery is super risky. You're cutting in someone's brain to try to get them not to be OCD. So a lot of different things there that can have a problem. This is interesting too. I'm gonna try to make a copy of this for you and scan it up because it has a lot of stuff on here about parent responses for children. Where they may be feeling the anxiety, not even know they're doing it, making it more difficult. Walking on eggshells to not upset the child. Hesitate, different things that kind of are creating some problems. So CBT is first line treatment for children specifically. CBT is it has an 80% success rate with OCD and anxiety disorders. And so those are things that are excellent to kind of work on in there as well. Realistic thinking, exposure, relaxation. These are all things, that can help with specifically, addressing that too. So the STOP acronym, if you're familiar with STOP, STOP stands for S-T-O-P. S stands for scared, so you're feeling scared. T, what are you thinking? O, other helpful thoughts. P, praise. Praise yourself for using these steps and plan for next time. So S, scared. Are you feeling scared? T, what are you thinking? O, what are other helpful thoughts? And then plan or praise. So you can practice, and the general idea is that when a panic hits, you just slowly make incremental changes to make that less till it's more manageable. So that's kind of what we're kind of shooting for in that. So, any OCD questions before we move on?
I have a question.
Yep.
It just seems like there's a whole range, from, I don't know whether to call it helpful OCD or an OCD that we don't have, and, what is pathological. So,
Yeah.
how do we tell? I mean, how long does something take for us to think that now that has gone into OCD?
So that's true of every diagnosis. Every diagnosis has a range of what's clinical and pathological and what is a mood swing. I had a mood swing. I have mood swings. Sometimes I feel better. Sometimes I feel worse. It doesn't mean you're bipolar. So it really comes into the word clinically significant. That's the phrase. And so is it clinically significant? Is it impairing? Anxiety works wonderful. So I watched a video. I don't have the video up for you guys, but it's a really good video on PTSD. And it talks specifically about, as these guys interview these soldiers, and they're all sitting around talking about their experience, and they're in group treatment. And they're doing some different treatment modalities. It's a neat video. And then toward the end of the video, they say to the guys, would you go back if you had the opportunity? And they're like, absolutely. And that's when you realize, at least when I watched it, I was like, you know what? They're having these symptoms of PTSD, this hypervigilance, these feelings. But truthfully, those are not negative symptoms when you're in a battlefield. Like if you are back, no wonder they want to go back. They're normal back there. This is survive. That's how you survive in that environment. Problem is you come home and you're in the living room with your dog and you still have these feelings someone's trying to kill you. That doesn't work so well. But you go in a war zone, that's appropriate. So there are some appropriate things people do. And you want to pay attention to that though, because so that's what was interesting in the PTSD stuff was just some of it's appropriate, for what they're experiencing. And so that's what you want to kind of look for. It is a problem here, but that doesn't mean it's necessarily the same everywhere. So let's look really quickly here at I want to get into this a little bit on dissociative disorder. Then we're going to go through the PowerPoint itself. Okay, so let's talk about dissociative disorders. Before we get into dissociative disorders, let me give you an image here a little bit of the trauma spectrum. Okay, so when we're talking about trauma, let me see if I'll draw it on paper because it's even easier. So we have a spectrum here from here to here, right? And so you're experiencing a level of trauma, something that happens, an event that occurs. Now, over here, this might be PTSD, right here, which is a specific event that something happens in, right? And so over here you might have BPD, borderline personality disorder, which I'll get to in a minute. And so if it's going this way, it's getting worse, right? Trauma goes that way. Over here is DID. So dissociative identity disorder is as far as you go on the trauma spectrum of symptoms. So if someone's gone through something traumatic, they're gonna present with DID. Now this DID is 97%. 97% of DID is what? Childhood sexual abuse. So if you have people disassociating 97% of the time, they've had some kind of childhood sexual abuse where they have split. You know, their body, something was happening with their body, but they weren't present. Emotionally, they were like, nope, that's just my body, I'm fine. And so they split. And so you'll find that's the primary cause when you start seeing that kind of issue. Now, let's go back to PTSD. Is obvious, sort of, because it's like there's a lot of press on it. It's a specific traumatic event. You went through something, and now you feel so differently because your car is impacted by another car, and now you're afraid every time you see quick movements of a car. I have a good friend that was in a party, and a confetti cannon, those big cannons, went off. You know, have these at churches sometimes or whatever events. It went off, but she was standing near it hit her in the face, and it tore her retina. So she's now she's your age. She's blind in one eye, and so anytime there's movement, any kind of quick movement, she's afraid of the other eye, or someone will get close to her, and then she's afraid of the other eye. That's a trauma response to an event. BPD, borderline personality disorder, is a little bit different because borderline personality disorder comes from not being able to connect with either primary caregiver as a child. So over early lifetime, they don't have that connection with parents and caregivers. And so, you know, mom was bipolar, you know, and just not available. She was either out running marathons, spending money, or she was in bed for a month, literally. And then dad was a Marine, and he was very authoritarian when he was home and authoritative, and then when he wasn't home, he was deployed, didn't connect with dad, didn't connect with mom. And so what you'll find with BPD is they're often very close to their siblings. They also, personality disorders in general, have a lot of plastic surgery as well. Something like 60% of breast augmentations are related to personality disorders, something like that. That's what some research has said. So you'll see a lot of those types of plastic surgery, things like that. Again, a lot of external trying to attract external, because they don't, to the inside, their core is just not feeling like it's loved and connect. So they have a very hard time. So what they'll generally do is externalize a lot of things. So what they'll do is they'll be in a relationship, and then they will vilify the person they're in a relationship with and say, well, my life would be better if they weren't like this, and then they'll kick them out of their life, and they'll have another relationship. And they keep kicking people out of their life because they can't internally say, I have a problem. They can't see people that are good and bad. We'll get into personality disorders later. I'll get into this more. But I want to get into it a little bit and just touch on it because it's part of the trauma spectrum. And so it actually comes from a different level of daily inability to connect. A childhood not being able to connect with their caregiver. So you see a little bit of difference there in how the trauma spectrum kind of works. Just so you know that. So let's get into this though and talk about dissociative disorder, since that's kind of what we're focusing on, which is also on the trauma disorder spectrum. So dissociative disorders can be depersonalization, derealization, dissociative amnesia, or dissociative identity disorder. So you can see different levels of. So dissociative identity disorder was formerly known as multiple personality disorder. And you say, I think there's a movie out called Split. There's some other stuff. Yeah, those types of, that's clear like DID. But you're going to find a lot of clients have the first one, where they feel depersonalized. I had a client recently say, I walked down the hallway at school and I don't feel like I'm in my body. And you'll hear children talk about it like it's very clear that they just feel like, I feel like my body's there, but I'm not there anymore. I'm afraid I won't go back to my body. Like I don't feel like I'm there. Yeah, I know I'm sitting in the chair, but I feel like I'm out someplace else. I'm not actually in my body. So that's one of the dissociative disorders you'll kind of run into a little bit. We're going to go through DSM in a minute too. So derealization and depersonalization are a little bit different. We'll get into that in a minute too. Derealization is one's sense of reality of the outside world is temporarily lost. So derealization is that what's going on externally is lost. In depersonalization, one's sense of oneself is temporarily lost. So you're going to want to know the difference between these two, because when you actually write it up for a client, you get it correct. So like their pediatrician knows which one's going on. You say the wrong one, they're going to be like, oh, that's completely different. So in depersonalization, one's sense of one's own self and one's reality is lost. So if these reoccur and disrupt the life, then the diagnosis can be diagnosed. Now, the client I told you about, 1 week had a problem, and then the following week had the problem about half the amount of time. So the treatment protocol that I was using was good enough to get him to respond, cutting the symptom in half within 1 week. So within 2 to 3 weeks, we're starting to see the symptom almost completely not being an issue. And that's no longer a coping strategy for the events and the stress and the feelings he's having in school. So again, you're looking more tip of the iceberg with this, where you're saying, okay, what's feeding into that? What is the way they're doing something? So you don't, when you're going to write up a treatment plan or talk about someone's treatment or write a note on somebody, you're not going to say patient has OCD. Okay, because it's kind of politically correct, and it also is just kind of the way it's written is just not really the clinically the best way to write it. The best way to write it is person presents with, or presented with. Met with Susie, met with client presented with signs of depression. So it's not who they are. You're not writing who they are. They are depressed. That's defining who somebody is. You're instead saying they presented with a certain way of dealing with things. Interestingly, I had a professor in my doc program who his big thing he was caught up on was the word handicap. You never say someone's handicapped, because handicap comes from being handy with a cap, begging because you couldn't work. So it's an identity of they have to beg in order to get food because they're handicapped. So they would say, the appropriate term would be, somebody with a disability. They had a disability, or they that type of thing. Not a disabled person that says that's who they are. Don't define somebody by that of who they are, but they are a person with a disability. Would be more of a appropriate term. Now it gets into PC a little bit, but I think the big takeaway here is when you're talking about somebody with a disorder like this, they presented with depersonalization or derealization. Not they are derealized. Like they're not. They don't constantly walk around that way. And so you want to just kind of know the difference there, so you get that wording kind of correct. So your amnesia versus your dissociative fungi. So again, subtype of amnesia. So dissociative amnesia involves a failure to recall previously stored personal information that cannot be accounted for, where the other one is a person departs from their home surroundings. So you got a little bit of difference there between amnesia in general. DID is the one you're going to get into most specifically. Patient manifests two or more distinct identities or personality states. So they have different personality states. There's research that shows some people with DID, talk about the power of the mind, some people have different personalities where one does not need corrective vision, one does need glasses. There are some, one is diabetic, the other one is not diabetic. So don't ask me. That's beyond my pay grade. But I mean, there are physiologically different bodies. Their bodies change among changes and those type of things as well. So, those type of things are a little bit different in kind of what you get into. Yes?
Do you know on record the highest number of personalities one person has had?
No. I don't know. I would love to know. I'm sure you could just Google that. But
Looks at 200.
really, I've heard of more than 200. But yeah, close. In the 200s. And the one that I know of that had 200, so we used to have a professor here named Dr. Keys, Ben Keys. And Dr. Keys actually worked with a lady who I think had over 200 personally. And then he got them all rectified down back to one. And I believe, if I'm mistaken, she became a psychologist and wrote a book on it. So, and he was on 48 Hours with that one. He was on like TV. So he's like specializes in DID. And so, in fact, I think one of the talks I heard him say is they drew a picture, and then she said, these are a picture of all the personalities, and then all the identities, and then someone said, well, where's the rest of them? She said, oh, they're behind that wall because they're not coming out yet. It's like, so there was like a picture wall in the picture too. Yeah.
Do the quantity of alters indicate severity of symptoms?
It might be how long or different things of what's kind of going on. As things cope, if a strategy didn't work, maybe they create a new one to try to cope and keep creating new ones. So yeah, it could be just the duration of the trauma or the event or whatever happened. But yeah, I'm not sure exactly how many would equate to what, but it's an interesting one to study. I think, yeah.
I missed something on the previous slide, the amnesia thing. I missed something on the previous slide. I don't know
Okay.
if it was the difference between amnesia and the.
So yeah, I think the hard part with working with DID is that it's so rare. I mean, you're going to see depression frequently. You're going to see anxiety all the time. You'll see OCD weekly. But, I've had one patient recently that has DID and had 9 alters, and it was but again, and it was a bizarre system itself, because in the system, it was kind of bizarre. Like it would have, like she would say, "Oh, my, I have one he's from England. He has an English accent, and he really likes you." And so I was like, "Oh, that's good," And so, but right now I want to talk to you though. I'm not trying to meet everybody, but there were 9 of them, and they would get darker and darker as they went along, more angry, more violent. That one I don't ever let out. If he ever gets out, it's going to be a bad. But the system was so dysfunctional, it was extremely confusing to work with them, because she would say, "Yeah, my husband really likes when what's his name comes out." I'm trying not to This is so bizarre. This story is so bizarre. I'm not even telling you the name of the altars, which I know all of them, because you might know that, like, you might actually know somebody with an altar named, so I was just like, I'm trying to protect her identity. But this one, this one's like, oh, he wants to come out Saturday, and I said, as long as I'm back by midnight, that's fine. So my husband loves it when he comes out. They go off and do a bunch of cool stuff. But it's like a guy, so it's like husband's hanging out with a guy and wife's body, and they go out and do guy stuff, and then like comes back. I mean, it's bizarre. You're following the story. To make it worse, I'm just being honest with y'all, right? I can be honest. It's also my first person in the day, so like, I'm like, there's just not enough coffee for that, like you're sitting here like, okay, whew, what are we talking about today? Like, here we go. Mm-hmm.
So do all the altars come back to one person, or do they constantly shift, from one to the other? Or do you...
In her case, they needed permission from her to come out.
Okay, so the person you were speaking to was the regular person.
Yes.
So she had to allow the other personalities.
Yeah.
Wow.
Yeah.
So in that instance, like, who would be the client? Is it like the main one?
Whoever's
Or
insurance.
they have different-
Yeah. So that's actually a really good question, and I would often think of that myself in the note. I'm like, who's actually my client today? Now I didn't actually have sessions with any of the altars,
Oh,
but she had them, and we're talking about them and talk about when they would come, and then she started using them less and less, and then I haven't seen them in this many years, and she began just kind of getting a little bit better. Now keep in mind, this goes back to what we were talking about earlier. I was not seeing her for DID. Okay, so like that was different than what I was seeing her. Like I was seeing her for depression.
How long did it take you or her to disclose this?
About 2 weeks. Yeah. So, but immediately when she says about the altars, I'm thinking, of course, childhood sexual trauma. So then on the intake, I'm kind of going a little deeper into some of those areas. And of course, she wouldn't disclose anything and was like, no, I don't think so. I don't think so. Just not, recalling, types of things. But I would pay attention to her affect, right? To see how irritated, agitated she's getting, to see if she'll be doing any switching. Switching, you can tell when someone switches, usually. Because it looks like their body gets turned off and comes back on. Like you shut the power off. Like those big things that blow up with air, those like big things you inflate. You turn them off, they collapse. They just kind of go down, then all of a sudden their face comes up. You can watch a lot of videos on it, and
I saw the videos that you posted. It's pretty interesting.
yeah, it's great. It's
How
like,
some of them take the people that were involved in their afflictions, like their personas. So that's one identity inside them, and how
yeah,
they're tormented by those people inside. It's just, wow.
this is where you get into what you're capable of treating and saying, okay, do I want to treat them for that? Because I don't have a ton of experience reconnecting altars to their original. I just don't have it. Like, I've only seen a couple, and you don't want to be like the psychology nerd who's like, cool, like I'm totally keeping this client, because like it's tempting to be like, you don't get to see these very often. This is cool, but you want to kind of pay attention to that, because if if it gets to the point where that's where treatment needs to be and you're not with that, you have to work within your level of whatever. Yes.
Okay, but as a Christian, do you ever come in contact with something like this and say, this has to be something spiritual tied in?
I knew somebody would bring this up, so yeah. So
I was thinking it.
so you're gonna. So there's clear descriptions throughout Scripture of demon possession, and I think, and again, I've also I was in pastoral ministry for 17 years, so I've cast my share of demons out of people, and that's a very real thing. It's different in DID generally. You'll find people who have demonic manifestations tend to be very centric on. They look like they're psychotic, like they have a psychosis, but the themes are often intense hatred for Christianity, intense hatred for God, the Bible, and things, and they'll switch their language, the way they talk, when somebody's kind of going into a demonic manifestation. Like the church I worked in, I mean, we were, me and the senior pastor were in the building, and it was a smaller church. So somebody came in the door and they came in the sanctuary and they looked kind of off anyways. You just looked kind of disheveled, kind of like, and they started looking at the ceiling, and I was like, so are you okay? What can I do for you? Anything? He's, no, I see your pastor hanging there right now. And started kind of growling and laughing and this whole like demonic thing and stuff. So, so we took care of that. Yeah.
I have a cousin who left home and didn't come back, and I'm wondering about this cube. Is that how it works? That somebody just walks off, disappears?
I don't know of. I tend to know people who they can disappear from time to time. One of the tests you're going to find when you're looking and you're saying, are they switching, between, altars? You may find, one of the questions I ask is, do you ever find that you lose gaps of time? And they'll say, yeah, that happens all the time. Like Saturday it was like noon, and next thing I looked at my watch and it was 3. I have no idea what happened between noon and 3. That's where you're going to find that they're likely switching, and how often that happens.
So that departs from home surroundings, so that's like means you're around, but you're not around mentally?
Yeah, they may not. The original person may not remember what happened when the altar was there. Now, the one client I had said they had control over that. They could still have some level of control. They would let the other altar take over the body. Yeah.
I've just seen like some YouTube videos of people who have DID and who are like pretty happy people, but they just talk about their altars and like their like internal world and everything. So I was just wondering, as like a counselor, how would you what would your goals be? Like if they're perfectly happy.
What's their goal?
Exactly.
Right. That's exactly right. I mean, because people will come in, like you'll have people come in and you'll have your thing, like that jumps out of like, oh, what's this? Or maybe trauma, and they'll come in and say, yeah, you ever experienced any traumatic? Yeah, well, I was raped when I was a child. And they're like, ooh, childhood rape, sexual assault, and that was this. And then, well, what are you here for now? Well, something completely different. Or yeah, I lost my leg in Iraq. Ooh, they're probably coming in for trauma from battle. And they come in, no, my marriage is really struggling. So they're not coming in for what you think they're coming. We're like, oh, I know what's going on here, and that's not at all what's going on. So you'll get caught by that every once in a while. See, that's where you really want to get into what their goal is, because you're right. Some people have gone through some things, and like the rape story I just told you about, she had been raped 3 times, 3 completely different scenarios, and which is a lot for somebody in their 20s, considering completely random events. And find out that she had been in therapy for 10 years over, and the therapist that did the trauma work with her was really good. So like there was a lot resolved there that had gone through. So that wasn't, even though it popped on my radar from my intake, that wasn't what I was seeing them for. So yeah, sometimes people have different things that are functioning fine. You want to see their level of function raised at where they're really struggling. So that's, again, clinically significant. What are we trying to accomplish here? To echo what you're saying, which is a great point, is think of the emergency room you're triaging. Somebody comes in and they're gushing blood from their arm, but they have asthma, and you're like a specialist in asthma. You don't need to be like, ooh, let's talk about your breathing. It's okay, let's see. I'm going to give you one of those little things you breathe in and blow the ball up. See how far it goes. I mean, they're bleeding. Like, they're dripping blood all over the place. So you're going to triage what they're presenting with, and what is they want to make themselves, better, or those type of things, So it's interesting like that too, because, I work in a secular counseling center. I counsel LGBTQ patients all the time. And I've counseled kids transitioning. I don't counsel them because they're transitioning often. You know what I mean? Like, so there are things you may deal with and things may open up, but what are you actually seeing them for? So you want to start with what they're really presenting with. you know, and not what we may think is the big factor here. You know, so one thing that comes up quite frequently, and you know, whatever your views are on this, I'm just telling you from my clinical experience. I have not seen anybody who has an abortion and been okay at all. Like, I mean, at some point in treatment, it comes up as a significant pain. And so if you have patients that have gone through that, that may come up weeks later because they're really coming in for something different. And then something may surface from it. Or they may say, I was in counseling for 2 years because of that. You know they've worked through a lot of that's gone on with that. So you're going to know different things that are key elements in their story that are influencing their symptoms, but it may not be what they're coming in for treatment for. Does that make sense? So yeah, you want to watch for that. Even so, somebody may have different issues, or they're treated for it. Sometimes people are medically treated and they're very happy with what's kind of going on. You know, they may present themselves with some kind of disability, and you think, you know what? Another one that reminds you of what you said though is autistic kids. Most autistic kids are really, really happy. And you see their low level of function and you're like, oh my gosh, it's so sad they're not functioning like normal. I mean, and I feel that too sometimes. And sometimes I'm like, but I don't know, man. I wish I could sit in a room and be happy anytime I wanted right now. You know, I mean, who's really got the short end of this stick, you know? I wouldn't trade what I'm saying. You know what I'm saying though? But sometimes people, the way they're presenting stuff, we think, oh, this is what they're really trying to deal with. When, you know, sometimes they're in a lot better place than you think in certain areas. So, but anyways, yeah.
Quick question. Your next slide was with all this we were discussing, but it says that patient manifests 2 or more distinct identities or personality states, not personality. So what's the difference between the two?
So again, a personality would be maybe more of a different persona that they kind of create, where a distinct identity is a different person. It is so some people will create altered personalities to sort of get through certain types of, you know, things. Like you may have a child that goes to school and they pretend they're an investigator, and they create this identity, but they're just trying to cope with the stress of school by acting different and looking at it through this lens. Where this is somebody where they literally switch and they're different. They have a different person that they've created inside of them. Their mind is created.
But it says personality states, but not personalities.
Yeah.
It's not the same.
A little bit different when they're a personality being a different way. So what they want to see more distinction. They don't want to see as much of a just change of kind of the way they are. Like they come to school and they start acting different. They go to church and they act like they're worshiping and stuff. Then they go somewhere else and they act like a drug dealer. And you're like, you know, ooh, they're DID. You know, no, they're not. They have different personalities and personas for where different places they are. This is more of a distinct switching of a different person is there. Yeah.
So that would be more like Billy the investigator, and then he becomes Billy the so-and-so, but it's always Billy.
Right.
Okay. As opposed to Billy becomes Charles becomes Claire.
Correct.
You know?
Right.
Yeah, it sounds a lot like with Beyonce, how she described her alter ego, Sasha Fierce. Sasha Fierce helps her when she gets on stage, she becomes a different person, and Sasha takes over.
That's exactly right. That's a personality. That's not, she doesn't switch into a different person.
Right.
Yeah. So, some controversies, is the disorder real or fake? Is it, if it's not fake, how does it develop? Are recovered memories of abuse in the disorder real or false? If abuse has occurred, did it play a causal role? The third one's very complicated because sometimes people have different recalls and you don't know how good of a historian they are about the recall. And so you don't even know sometimes with kids if they're making up a story, a complete fictitious story, or that's what actually happened. You know, and so you can see that from times too. So again, you've got 843 patients in a study here. Sexualized trauma, physical, either or both. You can kind of see a little bit here. of just where kind of some of the abuse has gone and what people have seen. So you can see though, the sexual trauma is pretty high up there. Physical is close in either or both. You can see some different ones as well with different cases. Yep.
Do the alters generally tell the truth?
The alters are like a different person. So like they may have completely different coping.
Okay, so how would you go about trying to figure out what actually went on?
Well, you may ask them about their process with an alter, and you may be able to say, okay, if so and so's here, how can I get so and so back here? You don't necessarily need to counsel the alters.
Okay. So you try to always go back to.
Yeah, I've never counseled an alter. I know they've had them. I know family members have had different things. They like different things. In fact, you may see a really good blend between is it a personality, is it not a personality? Are they actually switching? You don't want to just jump to DID with it too much. But prevalence of examples here too. DID in all racial groups, SDS classes. Prevalence varies with acceptance of dissociative phenomenon in culture. DID has been identified in all racial groups, all SDS classes, and all cultures studied. In some cultures, dissociative trances or possession trances may occur. In other words, where people try to channel people or things like that as well. And so you can see different kinds of cultures do different things as well. They're a little bit different. So integration of separate alters is kind of how the treatment goes. Reintegrating alters is kind of the theory. It takes years to do that. It's not a let me knock this out in 8 sessions thing. So unresolved issues, how might recovered memories be linked to DID? Recovered memories of childhood abuse are thought by some to be the cause of DID, but others to be falsely planted by therapists. So some people think it's just planted by the therapist and didn't really happen or it's not a big deal. Yeah?
Would EMDR be an effective treatment?
I don't know. It could. EMDR, so there's a lot of us look at EMDR and say, okay, EMDR is a good treatment and it works very well for trauma, so it could work well. The other thing is EMDR is CBT based. So how much is the CBT actually that's helpful other than the EMDR? My only hang up with EMDR is that when patients I've seen when they stop going to EMDR therapy, they often just stop progressing. So I think bridging that, we have some excellent EMDR therapists where I work, and watching them kind of say, okay, how they bridge that is really good. So EMDR is a great skill to learn. Just be aware, kind of what it's like for patients when they no longer have it. And I've seen severe trauma cases that EMDR did not work on. But that, again, that's just very, very rare. Most people have excellent results from EMDR. I would say 80% of people I see said, I went to EMDR training and it was excellent. And I really got better. So it's a good thing to learn. Let's roll through the DSM text really quickly, and then we'll kind of go from there. So OCD we kind of got into pretty good here, about the repetitive behaviors. I'll let you read through that on your own since we spent a ton of time on it. Prevalence, it's all in here too. DSM's got great stuff on it as well. Differentiate diagnosis, anxiety disorders, major depressive disorder. We talked about those a little bit too. Other obsessive compulsive eating disorders might be, we talked about that as well. Tics, psychotic disorders. Those things can all be kind of in there too. The most common comorbidity is anxiety disorder, some kind of anxiety. Also obsessive compulsive personality disorders, common. Between 23 to 32% of people when they become 18 kind of run into that kind of personality disorder as well. Body dysmorphic disorder, preoccupation with flaws in physical appearance that are not observed to others in their sight. Individual repetitive behaviors, mirror checking, excessive grooming, skin picking, So reoccurring acts that people do because they don't like their body. Preoccupation with if it's not better explained by some other kind of eating disorder. Body dysmorphia, though, can kind of get into a little bit. The big difference here is, well, let's talk about this for a minute because this is super controversial, and that's a good thing to talk about. What's the difference between body dysmorphia and transgender?
There's an issue with sexual identity, right? Like,
Nope.
gender identity.
No, but I'm glad you brought that up. So transgenderism and transgender individuals do not have, that is not linked to their sexual preference or sexual identity. So they're not at all related. So now if they have a worldview where gender's kind of fluid, they may be fluid in other areas, but it's not directly. So you have a client that is biologically born female. Ever since they were little children, they hated their bodies. They just didn't like wearing a dress. They screamed every family photo. Didn't like it. Finally, they're like, I really want to be male. I feel like I'm a guy trapped in a girl's body. Transition to male. So now you're 13, 14, 15-year-old transitioning. So what are some of the concerns you're going to raise? Like when you go to prom, are you going to go with a boy or girl? Because if you go with a boy, that boy would probably need to be homosexual, sort of. And then if you go, do you see the complication? So I bring it up because that does raise a question when your sexual identity now will be, it's a little off. Now you got a different decision to make with that and what's perceived. So it raises questions that kids will have to kind of, or whoever's transitioning has to kind of raise. But just because somebody transitions doesn't mean they have any change in their sexual preference or sexual, whatever. So, but the big difference is with body dysmorphia, they hate their body. They have features of their body they have an intense dislike for. They don't like that they have breasts. They can't believe it. They think they're horrible. They wish they never had them. That's body dysmorphia. They may also want to be a male, but their hatred for their body meets the criteria for body dysmorphia. Does that kind of make sense? There are people who are just like, I'm just a better boy than a girl. I just fit, I have all my friends, the stuff I like to play with. I just feel like a boy trapped in a girl's body. I don't hate my body. I just don't think it really fits who I am. That's not body dysmorphia. So you need to know the difference because you may have somebody, and those are loaded. Parents will come in and say, fix them, But the parents are too politically correct to say that. So they'll be like, we're open. We're open to this, what he's going through. We know he is a really, they'll mess up for a while. It's having a hard time, and but we are really open. We have been very accepting. Father, not as much as me, but I'm growing. He's getting better. But I'm open to it, but we just want to make sure everything's okay. So they're kind of like, we're not going to officially say this is wrong, but we're freaking out right now. So help. So that's where you kind of are going to come in. You're going to feel this pressure of like, is this right or wrong? So with clients that I have that are transitioning, I generally look at the best version of them. You need to be the best version of you. People are going to remember you for being a great friend, a great artist, being funny. Let's make you the closest to you can be and not worry about your gender. And so I found that if I can help kids become confident in who they are, they get less centric and less focused on their gender and their exterior shell of who they are in the view of everybody else. So I don't set out to not make them transgender, and I just don't pick that battle with them of like, I'm going to sign off on you being transgender, and I don't feel that I'm going to necessarily. So I don't typically go into that at all. I go into them, the version of them that they are, who they are, and them being as central to who they are as a person, who God created them to be as possible. And then how they respond to their physical body as a response to that is usually outside my control. But I feel like they're going to make a more educated decision, as centered as they can be to who God created them to be as an individual and their calling and their purpose in life than it is to anything else. Does that make sense? So I don't answer questions because people ask them. I'm picking a different question because I feel like it's going to help them make a better decision in general. So just kind of, that's where I go with it. Better or worse, you can do whatever on that. If you feel I'm wrong, totally fine. Be open to your input. But again, you can kind of get in here a little bit and you start seeing the body dysmorphia as in distinct more hatred. So girls are weak. Can't stand being a girl because girls are weak. That's body dysmorphia. You know, they don't like their view of women, and so they have these different views. So that's the kind of stuff you're going to run into. Compared to, I just don't really fit. Like I'm really not, I'm really more of a boy than a girl. That's different than hating body. Psychotic disorders, symptoms, those type of things, comorbidities. Hoarding disorders, we're not going to get into that a lot. I think we know where that goes with OCD and compulsions. A lot of people hoard things. They feel like they won't have things later if they don't keep them. They have security in all the things they keep and all the things they kind of take care of and all those type of things. It can be very, very difficult for family members to live with them. I know some extreme cases. One of them involved a pause. Okay. One of them involved a friend of mine who worked in law enforcement, and I won't disclose the city, but he recalled the story to me. And they had a husband called in a report that wife was missing. And so my friend went by the residence and said, can we get a copy of the credit card information so we can check, see if her card's being used someplace, Maybe she left the family, left. Maybe somebody, abducted her and they're using her credit, but they want to check her credit cards. But my friend went through the house and he realized there's some cleaning fluid and some freshly scrubbed things on the carpeting, and it was just kind of weird. So he went ahead and called an officer over, and a female officer, and said and it was around March, I remember, because it was March Madness, was on TV. But it just kind of said, hey, sit down, watch the game, stay with him, we're gonna get a search warrant for the house. Went to get a search warrant, took about 3 hours. The guy was really agitated, like, why are you here? Get out of my house, it's ridiculous, But the officer just stayed there and came back with a search warrant, began searching the house, and found part of her body in the garage in a bin. There was a saw he bought at Lowe's, an electric saw, and some other stuff that we'll get into. And so my buddy, of course, he gets arrested for murder. But my buddy was an investigator at the time, and he said he called one of the family members and said, hey, I'm really sorry to tell you this, but it appears your dad may have murdered your mom, and described. And the family member said, I can't believe it took him that long. And we're there. I mean, that's not like, what? I said, you have no idea what it was like living with her. And they apparently in the house there were entire rooms where there's a little hallway around the outside of the room where they could they would walk around the hallway, and inside every dollar bill was in plastic. Everything was in plastic Ziploc bags in the center of that, stacked in the middle of the house. So everything was super hoarded, a lot of obsessions, different things like that. And apparently husband, I don't know much about the story, but couldn't live any longer with her. So hoarding and things like that affect a lot of family members. They affect children. I've had numerous children with parents that hoard and just struggles with, I can't have my friends over. She won't let me have sleepovers because they don't want anybody in the house. They're afraid anybody's going to see the house. Those type of things. A lot of different reasons for hoarding And I can go through example after example, but they're all about the same. So you'll see some of these different things and diagnostic features of the obsession as well. Hair pulling disorder, you're going to see this one as well, where they'll start pulling out their hair in chunks as a way of coping, attributed not to another medical condition, but significantly distresses the impairment, social occupation function, not explained by other features and symptoms. You can read through here a little bit of, of what that kind of comes up with, but that's an actual diagnosis as well. And so is skin picking disorders, where they'll pick holes in their skin, things like that. Those also very similar to the obsessions and compulsions, right? So the compulsive behavior, these are compulsive behaviors that are specified. You get into that a little bit. And then medication-induced obsessive compulsive, you get into that a little bit too. Some medicines may have certain effects. Cocaine, heroin, you notice people who use methamphetamines tend to have sores all over their face. They'll have body sores because they pick. They'll have this uncontrollable picking that comes associated with methamphetamines. So you ever watch Cops or something like that? Because you may not see a lot of meth addicts wherever you are. But you'll notice like their skin, they'll have a lot of picking and things that have gone on.
One of the news channels they have on their website, the faces of men, showing people with the holes and marks on their face.
Absolutely. Obsessive disorders due to medical conditions, you can get into that as well. Again, somebody goes through a scare with a disease and suddenly they're super obsessive about it. You can kind of get into that as well. All kinds of different things too. Other unspecifieds. Then trauma we get into. RAD is serious. Reactive attachment disorder. One of the worst diagnoses I've ever seen in a human being. Just the level of fight in a child that has reactive attachment. Almost the child's minimally, if ever, comforted when distressed. Very rarely responds to it. They have limited positive affect, so they have all this acting out behavior and they can't be consoled with reactive attachment. Insufficient care, usually social deprivation in their upbringing, repeated changes of primary caregivers, those type of things. But again, very, very significant. Great one. You ever want to do any research on, or you ever want to kind of study a little bit? Reactive attachment disorder is serious. If you're going to work with foster children, get familiar with reactive attachment disorder, because those are the kids that come into care in the middle of the night. Somebody determines, hey, they've been neglected for a long time, and now they're coming into care, and now they have a suitcase that the social worker bought, and they have a gift card to go to Burlington Coat Factory and pick out clothes. And now they're going to go and try to get awards that have nothing but what's on their back. And they have to go to school the next day in a new school, because that's where the foster parent lives. So they have a lot of very, very difficult attachment issues for kids who've been involved in foster care. Just be aware of it. So, social engagement disorders you can get into. You won't see that as much, but you'll see some of it. PTSD we got into a little bit. Some children can have it, but usually, again, it's a little bit older. Aversions to traumatic events. There's a lot of information on this. Read through it a little bit, kind of find out what it is. But again, you're looking primarily at length of time on this, and you're looking at some of these behaviors right here that will kind of come in. Just the hypervigilance is a big one. They're just super alert. You'll find somebody driving down 264 and a bag will float across the road, or there'll be debris in the road and they swerve. And you're like, why do they swerve? It's just a bag. You'll find, I've had patients say every time I see somebody I swerve because I can't drive over a foreign object because that's when the bomb went off. So we live in a high military area like that. You'll find all kinds of things on the media on 4th of July you know, hey, be kind, be mindful in your neighborhood of people who have served. You don't just want to start blowing off, you know, fireworks in the neighborhood. You know, that sound, you know, those are all very triggering. So, you know, on the hypervigilance, exaggerated startle response, problems with concentration, sleep disturbance, irritability and outbursts, and you're looking for depersonalization, you'll see, feeling detached, derealization, you'll notice, and you're looking for the flashbacks and dreams. You're going to see nightmares, dreams, reoccurrence. Incidentally, dreams are a good thing to look into and study a little bit. Dreams are really when your mind is at rest. Your mind tries to make sense of things that don't make sense or you can't make sense of when you're cognitively awake. So when you're awake and you're like, why did my parents not treat me right with this? You know, you have to function. So you're like, don't worry about that. So just write your paper. Just do your discussion post. Gosh, let it go. And that's you. But when you sleep, your brain is like, what can we work on? Let's put this in a good place. And all of a sudden, you start having these bizarre dreams. So people who do dream analysis are looking for themes. You know, I was in a field, or I was in a desert, and I was in this place where it was desert, and I couldn't get any water, and I was choking. You know, and you start looking at themes over and over again and feelings, and your mind's trying to process a lot of what's kind of going on. So you'll find out with dreams and sleep association stuff. So PTSD, read through it a little bit. We teach entire courses on that. I don't want to get too much into it other than when you see it, that event that keeps reoccurring, you're looking more at PTSD in the trauma response. And then we talk about the trauma spectrum. Acute stress disorder is, again, direct experience of trauma, witnessed in person the event. Again, learning of something, exposure, presence of 9 or more of the following symptoms, and negative mood, dissociation, avoidance, arousal, you go through here and stuff. Note symptoms typically begin immediately, but persist for at least 3 days, and up to a month is needed to meet criteria. At least 3 days and up to a month. So someone's likely to move from acute stress disorder into what? PTSD, right.
Yeah.
So if it's short term, if it just happened, they just were in a car accident, they're in the hospital, their wife died, and they're just freaking out, and they're like, I don't know, you know, they're likely to have acute stress disorder for some time. And immediately they're coming into you of like, go see somebody now. They're coming in, and they may say, I have PTSD, but they don't have PTSD yet. Yeah.
Well, with acute stress, isn't that technically a normal reaction to a traumatic event?
Mm-hmm.
So it's, well, I mean,
Only you look at 9 of these factors.
Okay. Because, I mean, isn't technically, I guess it's kind of like what you were saying, that there's an appropriate time and place for different things, like you were talking about anxiety.
Exactly,
PTSD.
clinical significance. Yeah, obviously negative mood. It's kind of like grief and complex grief. You know, complex grief is when you're just not kind of getting past it. But the feelings of loss are real. You know, I mean, there's grief, there's a pain. It doesn't feel okay. It's not okay. We're not designed to say goodbye to people and things. We're just not. You know, we're gonna hurt, and so that's not pathological. But if you're disassociating, can't find any happiness, sleep disturbance, I mean, and you're just for going on some time, you can have that. So how clinically significant is the term? If it's really, really bad, then it's going to meet this criteria. If it's just like, you know, Billy's had a hard time sleeping since the accident, and he keeps waking up thinking he's in a car still, you know, that may be a little bit different. So, acute stress, adjustment disorders, we kind of get into already. You know, so you're looking at, again, notice that it's under the trauma stuff, your adjustment disorders. You're getting into marked distress that's out of proportion to the severity and intensity of the stressor. So they change schools, but their level of, they don't want to go to class, they don't want to walk down the hall, That's not really a normal proportion. This is what you're talking about right here. Well, that doesn't help at all, does it? So, okay, out of proportion with severity is the difference where it's more of a significant clinical diagnosis. You know, they lost their job, they feel like they're gonna be homeless, and they're crying and they're hyperventilating. You know, well, you know, that's out of proportion. Same other person may lose their job and go, fine, I didn't like that place anyways, I'll go work across the street. Some, you know, that's proportioned. You know, so you want to look for clinical significance. So then you're looking at with depressed mood, with anxiety. Remember, these codes here are not what we put in our DSM stuff. Those are the other DSM codes. They put them in here for people who are still transitioning. The F10 codes are these right here. That's what we use. With depressed mood, with anxiety, mixed or unspecified, those are the ones I tend to use. You may have a disturbance of emotional conduct when they're really acting out and there's a behavioral component to it. But I go with F40, 320 on a lot of diagnoses, or F40, 321. If they're feeling that. So if they're adjusting to an event and they're just like really sad, you know, then that's one thing. If they're like a breakup with a relationship and they're just not recovering well and spend months and they don't, you know. Now if they went to grad school and they're worried about finances and they're not really sure, and you had to cut back on your hours so you can get your work done, and it's more work than you thought it would be, that's adjustment disorder with anxiety, right? Because you're more worried about things than you are totally profoundly depressed over it. The trick to this, instead of just anxiety disorder or depressive disorder, is that it's linked to a specific transition or an event. You know, so there's something that happened they're adjusting to. So other trauma disorders, unspecified trauma disorders you can get into. Dissociative disorders we already got into a little bit. DID, listing the symptoms there. We kind of covered that in detail. Differentiated diagnosis. These are where they get complicated. Then it's like bipolar disorder with psychosis. Whoa, how's that different from schizoaffective disorder and psychosis disorder this and schizophrenia? And so that's where you kind of got to open the DSM once your client's gone and figure out what's going on. So that happens a lot where you're like, what just happened? So I will warn you on this too. This brings up a good point. When you have psychosis out of nowhere, get a medical exam right away. Because if there's lesions in the brain, they'll have some see lights and they'll looks like they're presenting with us. Sometimes there's a brain tumor. I've had 2 of them that had brain events or tumors. That it was suddenly out of nowhere they just started. You know, he didn't normally use that. When did it start? It happened about 3 weeks ago. You know, now Billy keeps pretending he has an imaginary friend. Let's get him into a doctor. Let's look medical. What's going on in the brain right now?
So do you contact your medical doctor or?
Yeah, sometimes. Or if the medical doctor sends it to me, then I know that's probably already been done.
Okay.
You know, but if I'm concerned about a medical response to something, I'm looking to say, well, something structurally could be changed in the brain and could be affecting you. One of them I was like, this is not behavior. I can just tell. Too sudden, it was nothing happened, no precipitating event. Out of nowhere, you just don't get psychotic. So it's kind of like, this is weird. Send them in at a cyst. And then they did surgery on the cyst and everything returned to normal. I had another one with lesions in the brain that acted like a migraine, then they had some bizarre behaviors. They see some lights. So remember, of the brain's function, 60% of what your brain does is vision. 60% of all function of the brain is your vision. So when you start seeing stuff, perceptions in vision, problems of vision, those are typically brain related, not necessarily the lens. So if you're seeing lights or seeing things like that, you're going to be looking at, they need to be considering what's going on in the brain. So you want to make sure that's covered. Because you can work a long time on somebody that has a brain issue, and they're like, whoops. You know, I mean, I've had patients or a psychiatrist that said, VA hospital said, he's never going to get any better. He has a traumatic brain injury. That's another one. If you have somebody with a traumatic brain injury, you're kind of off the entire map here. You're looking at, now you can go cognitive behavioral therapy and say, okay, let's try some different ways of viewing things to have him adjust to his current brain.
Mhm.
You know, but you're not looking at a typical brain change. You're looking at the structure of the brain injured. That's a whole different thing. So stroke, different things like that, or they're having tingling. You're looking for all that stuff if you see behavior, slurred speech, anything like that. You want to go medical exam immediately, type of stuff. I've sent people to the emergency room from my office before, just because they come in and they're like, I'm just not thinking clearly, Or you have an older person, 50s and 60s, and they're like, I just keep forgetting. I didn't remember I parked my car. And then, and he gets really angry. He gets really angry, starts smashing things. Is that new? So if you for fear you're losing your memory, you'd be angry too. So anger comes with Alzheimer's and dementia stuff. So the faster somebody can be diagnosed with dementia, the faster they can get on medication that slows the progression. Generally, people die within 8 years of diagnosis. So when they actually had the diagnosis for dementia, it makes a difference on life expectancy. You don't have to tell them that. But I mean, it's general because you don't know when they have it, if it's early onset or what's going on. But there is a lifespan issue related to dementia. So just be aware of that. So when people present with that, you can kind of get them looked at medically. Yeah.
So do you usually ask your patients, your clients, if you're like, have you been to a doctor recently?
Always, yeah.
Yeah. Is that usually part
When's the
of your
last time you saw a
intake?
doctor?
Is that part of your intake?
My intake, I'll start thinking medically first. I think, is there a medical explanation for what's going on? Now, if they're like, he doesn't want to go to school anymore because last week he was bullied and some kid pulled his pants down the hallway. Now he's so embarrassed, he doesn't want to go back. I'm not going, maybe you need a brain scan. I'm like, I get, okay, I get what's going on with that. But if it's like out of left field and there's some bizarre behavior and something changed recently, I want a full workup medically. Now, two things come with that. One, their primary care is going to go, that's the therapist I want my clients to see. Because they're looking at everything. If I miss something, they're going to try to catch it. I've had many physicians call and say, what are you seeing? Because this is what I'm seeing. Let's figure this out. I don't know what's going on. So we collaborate. So you want that high collaboration with medical stuff. So anyways, that's about all we want to get into. We got into the disassociative stuff and we're out of time. So questions, comments?